Hello, I'm Woong Jin BAE from Seoul St. Mary's Hospital. I'd like to talk about sexual function preservation surgical techniques for BPH. Even though multiple techniques and technologies are available for surgical treatment of BPH, various sexual side effects including retrograde ejaculation, orgasmic dysfunction, and erectile dysfunction have been reported with the majority of surgical modalities. TURP and alternative treatment options such as laser prostatectomy constitute the mainstay of surgical treatment, and they have much higher rate of sexual dysfunction than medical treatment. Usually, sexual side effects from surgeries can be broadly classified into three categories: erectile dysfunction, ejaculatory dysfunction, and orgasmic dysfunction. However, the pathophysiology underlying these changes remains poorly understood. Firstly, regarding erectile dysfunction, animal studies have positive data with the common alterations in smooth muscle relaxation, either through a decrease of nitric oxide, autonomic hyperactivity, or pelvic atherosclerosis, and alternative pathways such as Rho kinase and endothelial activity. On the contrary, a large number of men report worsening of erectile function following treatment for BPH. Thermal injury to the cavernous nerves and blood vessels, as well as inadvertent violation of the prostatic capsule during surgery. Potentially damaging nerves has been a proposed factor contributing to postoperative worsening erectile dysfunction. Of the sexual parameter studies following BPH surgery, the orgasmic function is the least well evaluated and understood. It is thought that retrograde ejaculation may contribute to an altered orgasmic experience described by some patients following surgery. As a result, ejaculatory dysfunction represents the most commonly reported side effect of many treatments for BPH. In the normal genitourinary tract, the smooth muscle of the internal urethral sphincter plays a critical role in maintaining antegrade ejaculate function. So disruption of this mechanism is thought to be the predominant contributing factor underlying treatment-related retrograde ejaculation. So maybe patients have to choose between ejaculation or micturition when they decide which kind of surgery for BPH. I'll introduce you how to minimizing sexual dysfunction after BPH treatment like this contents. We have to think about novel surgical methods or novel treatment modalities. Retrograde ejaculation is because of absence of bladder neck or internal sphincter closure, and complication of BPH surgery is the most common cause of anatomic retrograde ejaculation. Even though the internal sphincter or bladder neck integrity is important for physiologic ejaculation, many studies reported that sufficient supramontanal prostatic tissue is the key to maintain antegrade ejaculation by preventing seminal fluid from reaching the bladder. This is interesting images using color Doppler ultrasonogram during ejaculation. When ejaculatory stream spurting to bulbous urethra, closed supramontanal portion is observed in sonogram. Therefore, many kinds of ejaculation-preserving techniques are introduced. Transurethral incision of bladder neck with preservation of proximal to the baromontanum was reported for primary bladder neck obstruction in young men. Ejaculation-preserving TURP is almost the same method. Aloshi conducted a prospective study of 89 patients with short and long-term follow-up. Authors reported that The important thing is resection of lateral lobe to the capsule and the ventral side to the level of baromontanum with avoidance of paracollicular digging. 90% of patients reported preservation of ejaculation at 3 months, but 8 patients received the second TURP. Long-term complication rate described about 9% of ejaculatory dysfunction compared with 65% of previous data. Similar to TURP, retrograde ejaculation is the most common sexual side effect after HoLAP, with incidence rate of approximately 70 or 80%. Especially inoculation in HoLAP is thought to be the predominant factor contributing to this high rate of retrograde ejaculation. This is pilot study of ejaculatory hood sparing HoLAP in Korea. 26 patients received the ejaculatory hood sparing technique during HoLAP. In the ejaculatory hood sparing group, paracollicular and supracollicular tissue over 1 cm proximal to the baromontanum was preserved. The ejaculation preservation rate was 46% in ejaculatory hood sparing group and 27% in conventional treatment group, but there was not significant difference between groups. They concluded that simply preserving ejaculatory hood tissue did not prevent unejaculation. Some apical tissue needs to be also preserved. However, there is some report with ejaculation preserving technique in PVP laser. After sparing paracollicular and precollicular tissues, 92% of patients after TURP or PVP laser showed the preserved ejaculation. Taleb described the ejaculation-preserving PVP technique in AUA. They preserved bladder neck, precollicular tissue, and ejaculatory hood. They reported the 86% of patients were preserved after treatment. Recently, another group reported prospective randomized trial. Ejaculatory hood sparing vaporization was performed with preservation of the paracollicular and supracollicular tissue proximal to the baromontanum in 25 patients. Ejaculatory hood sparing PVP starts by marking the area. Paracollicular and supracollicular tissue present almost 1 cm proximal to the baromontanum using the coagulation mode, and the obstructing prostate tissue is vaporized while preserving the ejaculatory hood without vaporization or coagulation at the marked hood area. A significant reduction in the ejaculatory domain of MSHQ score was reported after standard vaporization at 6 and 12 months, comparing with no significant difference after hood-sparing vaporization. Antegrade ejaculation was reported in 85% and 31% of patients after hood-sparing and standard prostate vaporization, respectively. Post-operative urodynamic assessments demonstrated a significant comparable decrease in the bladder outlet obstruction after hood-sparing vaporization or standard vaporization. At 1 year, the overall retreatment rate was also comparable in the two groups. Then let's move to ejaculation-preserving novel surgical methods. I'd like to suggest 3 surgical alternatives: prostatic urethral lift, water vapor thermal therapy, and aquablation. This data is to compare prostatic urethral lift with TURP. The difference was further demonstrated in the BPH ejaculatory function category, as 100% of patients in the prostatic urethral lift arm had preserved function. However, 34% 34% of patients in the TURP group reported they could not ejaculates at 2 years. Prostatic urethral lift resulted in superior quality of recovery, ejaculatory function preservation, and performance in various studies. So EAU guideline recommends to offer prostatic urethral lift to men with LUTs interested in preserving ejaculatory function. Resume water vapor thermal therapy is also reported to remain ejaculatory function, and no adverse events related to ejaculation were reported. This paper is 6-month safety and effectiveness prospective data in men with large prostate volumes. MSHQ ejaculatory domain decreased 2 points from baseline and 19% ejaculation dysfunction reported. In addition, Cochrane review reported that aquablation may cause slightly less ejaculatory dysfunction than TURP, as measured by MSHQ. In conclusion, surgical treatment for BPH are associated with variable rates of sexual side effects. Recent studies demonstrated that anatomical strictures, including ejaculatory, hood, and apical tissue other than bladder neck, help maintain adverse events. The more minimally invasive therapy options for male voiding dysfunction show improved preservation of sexual function and health. Thank you for your attention.